Hi, everybody. You've met Tommy already. I'm Gale Kittle. I'm from Barrow Neurological Institute in the United States, and I do a lot of the training for ALS clinical trials for the outcome measures of including ALSFRS-R, vital capacity, and muscle strength testing. Did you want to add anything about you? Okay, great.
Yeah, you know me already, but besides doing clinical trials, I'm also delivering training sessions for under the TRICALS flag.
So we were asked to provide a high-level overview of some changes that recently occurred regarding the ALSFRS-R that we're going to talk about. But first, I just wanted to give you a little bit of background about the scale in case you're not familiar with it. The ALS Functional Rating Scale Revised is a commonly used questionnaire almost in any late-stage clinical trial. It's almost always either the primary outcome measure or secondary outcome measure. It's a 12-item scale measuring the performance of daily activities. The scale is divided into 4 functional groups, including 3 questions addressing bulbar function, 3 questions addressing fine motor function, and 3 questions addressing gross motor function, as well as 3 questions addressing respiratory function. So each question is scored on a scale of 0 to 4, and 0 means that there's really no function in that question, to 4, which is normal function as compared to prior to ALS. So in research studies, the evaluator who is administering the scale always needs to be certified, which means they've been trained and passed reliability testing to receive their certificate. And Tommy and I primarily have done that training historically. So as I said, Tommy and I provide most of the training on the scale. Tommy on behalf of the NCALS TRICALS European group, and myself on behalf of the BNI NEALS group in North America. Many evaluators who are conducting this assessment, depending on what studies they're working on, may have been certified by both our entities, by both TRICALS and NEALS groups. And over the years, we have become aware of significant differences in the guidances that were provided for scoring the ALSFRS-R between the NEALS and the TRICALS group. So this was becoming problematic, confusing evaluators who were certified on both NEALS and TRICALS, and the certificates were not interchangeable at that time. So over the past year and a half, the 2 entities came together, Dr. Jeremy Scheffner and myself from NEALS, and then Dr. Leonard Vandenberg and Tommy on behalf of TRICALS, and then Angela Genge was also very involved in kind of facilitating this whole project. So what we're going to do now is just provide just a high-level overview of the differences in scoring between this harmonized version that we're now working with, where we have come together and harmonized the guidance. So we are calling that the harmonized ALSFRS. Everything that we're providing to you today it has been published recently in a research article in the ALS and FTD journal, and either Tommy and I are, if you reach out, are happy to provide you a copy of that. So everything is there, the new SOP as well as the differences that we're going to highlight. So, Tommy, do you want to start with the bulbar questions and just...
Yeah, so how we continue, Gale and I, is like we will present you the 12 items on the ALSFRS-R, and on the table below or on the table on the next page, depending on the amount of differences, we have highlighted which scoring was varying the most. This doesn't account for training. It's well like a high-level overview on like what are the differences.
Yes, you can be relieved. There's no training.
Yeah. So here you will see like the first question on speech. So we thought initially on tricals to do things slightly differently, and later that caused problems. So we solved that problems, luckily. In the item number 2, intelligible with repeating. So if a patient was rated 2 under the new standard operating procedure, that was defined as some repetition required to understand speech in daily conversations. Whereas under the trical standard operating procedure, we thought it was a good idea to incorporate a cutoff of more than 25% of the time. It didn't turn out to work pretty well, so we harmonized it into the word significant. So if the person living with ALS needs to repeat him or herself with significant repetition into a normal conversation, so not at a party, then the person will be rated a 2 on this item. Same we did for salivation. The trical standard operating procedure continue with using the cutoff of 25% of the time for moderately excess saliva or have minimal drooling. So we defined that if there is more than 25% of the time a tissue needed, or if there is more than 25% of the time drooling present, then a patient will be rated a 2 under the tricals SOP, whereas under the Niels SOP it was occasionally dabbing around the mouth. Wording might be similar, just slight differences in interpretation, and we harmonized that into the updated SOP as occasionally dabbing into of the mouth with the tissue during the day. There was also some differences on item number 3, so slight but definite excess saliva in the mouth and may have nighttime drooling. So under the tricals SOP, that was with or without nighttime drooling. That meant that there is an excess saliva but no need to mop up. And under the Niels SOP, it was phrased as swallowing more frequently. So again, maybe just it seems to you, if we present it right now, just minimal differences, but it would have been, or it could have been occurred that if you use the tricals SOP and the Niels SOP, that there is variation in scoring, and therefore you might not find the potential treatment effect. So that's what we wanted to avoid, and therefore harmonized it into some excess saliva, but no need to mop up on item number 3. And the last item in the bulbar section is swallowing. And we had some differences here on item 2, 3, 2, and 1, which the main differences between item number 3 and number 2 were the consistency, whereas under the new standard operating procedure, it's like if people needed to cut food up, people will be rated a 3, whereas under the tricals SOP, it's stated as like the food needed to be liquidized. And we had some additional criteria in the tricals standard operating procedure for people who not have a gastrostomy but needed one. So, and we harmonized that into the significant weight loss, or people that cannot maintain their own weight by their oral intake due to swallowing difficulties. So that will rule out people with only atrophy and no bulbar involvement. And we harmonized item number 2, the dietary consistency changes, whereas if people either avoiding food or the food needs to be cut up into smaller pieces to be able to swallow, then people will be rated a 2 and a 3 if they have early eating problems, and there's only coughing or it stays stick in the throat, but there are no other changes there.
Okay, and then I'm going to talk about summarize the changes in the fine motor function section. Starting with handwriting, really we were very much aligned on the guidance. Maybe some things were worded a little bit differently, but the guidance was identical between the two, so there was no change there. There was some changes in cutting food and handling utensils. This would be 5A for patients who do not have a feeding tube or do have a feeding tube but don't use it for their primary method of caloric intake. So for a rating of 3, somewhat slow and clumsy but no help needed. The major difference here between the Neals and the Tri-Cals was that for Neals there was just some difficulty cutting utensils, but they were still independent and not using altered utensils, so adaptive tableware or silverware. Whereas for the Tri-Cals guidance that if they could still be rated a 3 if they were using adaptive silverware of any kind. So we did harmonize this that there is some difficulty either cutting food or holding utensils, but they're able to do this independently. So we took if they're using adaptive tableware, that would be a form of assistance, so they're not independent. So a 2 is where they are now using adaptive tableware to help them. So we also did some clarification in question 2 where they can cut most foods, although slow and clumsy, but some help is needed. And it mostly boiled down to how much they were able to cut their foods. And we harmonized this into needing occasional assistance for cutting food, but being independent for the task otherwise. Whereas a rating of 1, where food must be cut by someone but can still feed slowly, again, there was some differences in the level of cutting and assistance that was needed for cutting. So we have harmonized this into assistance is required at least half the time for cutting, but not for feeding. And it just seems like it's very much more straightforward with the harmonized guidance. There's no change in the rating for those patients who do have a feeding tube and do use it for the majority of the nutrition. And then for dressing and hygiene, so for Neal's, a rating of a 2, where they needed intermittent assistance or substitute methods. Basically, we said that they were making modifications, but they were not requiring any caregiver assistance, whereas the Tri-Cal guidance said that they could be receiving intermittent assistance from either a caregiver or the modifications, so they were involving a caregiver. So our harmonized scoring is that they are now using methods different than prior to disease onset, and that minimal help is needed either from a caregiver or use of assistive devices. So the minimal help from a caregiver or occasional assistance from a caregiver is used for the harmonized. And then on 1, needing an attendant for self-care, the Neal's guidance was that this means daily caregiver assistance with dressing, but the patient has some level of function, while Tri-Cal's was saying that this means that all aspects of the task require assistance, but the patient is able to assist the caregiver. So very similar, and so this is harmonized into both dressing and hygiene activities require a significant level of caregiver assistance, but the patient is able to assist the caregiver. So that would be for I believe that is for the fine motor movement. Tommy will talk about gross motor movement.
And we were consistent on item number 7, turning a bed and adjusting the bedclothes. Similar for item number 8, walking, there might have like different wording, but it didn't impact the scoring under either the Niels SOP or the TriCal's SOP. And similar for climbing stairs, we were consistent here. Again, wording might have been used differently, but from an outcomes perspective, it didn't change the scoring.
And then on the respiratory questions, on question 10, where we asked about dyspnea or shortness of breath, this probably had the most major discrepancy in the scoring guidance that could result in a scoring difference of 4 points, depending on which scale that you were using. So when we ask about breathlessness, if you were rating by the Niels SOP, that if a person was using any form of non-invasive ventilation, you were to ask and score by their shortness of breath during the times when they were not using the non-invasive ventilation. So if you had a patient who was using BiPAP at night but not during the day and did not have shortness of breath during the day, they could be scored a 4 because they were not having any shortness of breath when the NIV was not being used. For the TriCal's guidance, if someone was using assisted ventilation during the night or day for ALS, they were to be scored a 0 automatically because they were using that. So that same person could be a 0 on the TriCal scoring. So after we discussed this, we decided that the harmonized version would be to rate them by when they are not using their non-invasive ventilation. So that would be the harmonized guidance for question 10, and then there really were no inconsistencies with orthopnea or respiratory insufficiency.
Could you not get enough of Gale and myself? Tomorrow we will have a training session on ALSFRS-R Harmonized Slow Vital Capacity and HHD in the conference center, followed by drinks.
Okay, and that was what time? And where? What time
Sorry, it's from 6 in the conference center.
Okay.
Thank you, Tommy and Gale, for your presentation. I think harmonization, I said it, harmonization can only be a good thing. So thank you for that. But interestingly, from a different perspective, I've just had a text from a patient who's watching online, and they said that the ALSFRS-R, from their perspective, doesn't feel like a useful tool and a useful thing from their perspective. But I know why we do it, but it's considering the patient's thoughts too. Is there any questions from the audience? Yes, there's one. Richard has.
Thank you. I'm going to group the questions together. So hang on a second. This is from Lynn, ALS Problem Solvers. ALSFRS-R is an okay measure for lower motor neuron function, but is it a poor evaluator of upper motor neuron involvement? And how is, this is from Kevin Robinson at Niels, how is salivation evaluated if medication is used to manage? And on a linked one, is which medication to use for excessive salivation? Scopoderm is practically unavailable in Switzerland.
We will break it up. So I will do the first one about the upper motor neuron. So, and it has been said, the ALSFRS-R also in the comment that Rachel gave or reflected by the patient online, yes, the ALSFRS-R has a lot of limitations. And I only think that currently with this outcome measure, or with the ALSFRS-R being the primary outcome measure or the secondary outcome measure in the majority of the clinical trials, that's because we do not have an other outcome measure that, like with the heterogeneity of the disease, capture or is able to capture change for people with the variety of symptoms. And Yes, indeed, like it's more of a lower motor neuron scale. However, on the first item on bulbar, like people can have a pseudobulbar effect, which can be reflected in, or will be reflected in the ALSFRS-R, same as stiffness, like that will reflect in like dressing or washing difficulties, walking difficulties, turning in bed difficulties. So although it seems on at first hand that upper motor neuron is not, or most of the questions do not capture upper motor neuron. However, if you look into every item there, it will be reflected somehow.
And there are a variety of outcome measures that are under investigation now, including biomarker outcome measures such as neurofilament, which I'm sure we'll hear a lot about in the bigger symposium. So as far as salivation goes, and this is in publicized in the SOP and the guidance, that the patient is to be rated on their level of salivation regardless of whether they're on medication for salivation. So this one could fluctuate depending on how well their medication is working, but if they are taking medication for excess salivation, they should be based on how they are doing on that medication. So, and then it's really not within the scope of the scale to determine which medication is the better treatment.
So Tommy and Gale, I wanted to thank you. I have a thumbs up for Tommy, for my patient. Just says thank you for the answer. So may we thank you, Tommy and Gale.